Good afternoon. My name is Brandon Pate. I'm a community health paramedic at MedStar Mobile Healthcare in Fort Worth, Texas. I'm honored to be here with you today, and I'm excited to share with you the work that we do in our community to enhance health literacy and improve patient outcomes. To give you a little bit of background about myself, I've worked in emergency medical services for 15 years. I first started my career off in rural Texas, worked in several communities, and then I found my way to MedStar. There we go. About 6 years ago. The first 2 years at MedStar Mobile Healthcare in Fort Worth, I was functioning in the capacity of a traditional 911 paramedic. I then transitioned into my current role, where I'm a critical care paramedic and a community health paramedic. As we talk about the work that we do there in Fort Worth, I think it's important to provide some background and context for those community health programs. So here's a little bit about MedStar as an organization. MedStar is the exclusive emergency and non-emergency ambulance service provider for Fort Worth and 14 surrounding cities. We're a governmental agency that serves a population just over 1 million people. We do 140,000 calls for service annually. And an interesting fact is, from a financial perspective, we are completely self-sufficient. We receive no tax subsidy for the services we provide. So in July of 2009, MedStar developed and implemented a community health program called the High Utilization Group. And this program was designed to address the ambulance super users. And we define those patients as those that call for an ambulance 15 times or more in 90 days. Many of those patients that were first enrolled were homeless, and had significant mental and behavioral health disorders. As a paramedic in my 15 years, it's always been challenging and sometimes frustrating when you would see the same patients for the same medical issues, and the only option you had was to transport them to an ER and then repeat that a few days later, sometimes even the same day. So that's what prompted the development of this program. And this was essentially the inception of mobile integrated healthcare, as we call it now, abbreviated MIH. Since that time, mobile integrated healthcare has evolved and expanded to include several other programs. However, that overlap of mental health conditions and behavioral health disorders remains quite significant. Today, I'll speak on the broad aspects of the community health programs that we offer and the interventions we implement to promote health literacy and improve patient outcomes. The mainstay of mobile integrated healthcare is to identify and address the social, economical, environmental, and healthcare-related gaps, and to develop interventions and solutions to those gaps that are patient-centered, collaborative, and integrated with the other factions of the healthcare system. As we talked about earlier, wanting to increase the PCP's reach into their patients and, expand that time so that there's more of an opportunity to do this, this is where we come in. This is where we take on that role and we become the eyes and the ears of the physician. We couple that gap analysis with preventative services and healthcare system navigation to ensure the right patient is receiving the right resource at the right time in an effort to produce the right outcome. On the right of the screen, you'll see some of the most common gaps that we identify, from food insecurity to transportation. Some patients do need a primary care doctor. They don't have it. Some patients need funding, and we work with them to get that. And of course, a number of our patients do require the mental health resources that's provided in our community. This approach coincides with the constructs of the IHI AAA to improve the community's health, to improve patient satisfactions, and to reduce healthcare expenditures. And we have this opportunity to advocate on behalf of our patients, to assist them in navigating the healthcare system, and to educate them on their disease processes and medications by seeing them in their homes twice a week. We're spending several hours with these patients and working with them to identify goals and to address those goals. As ambulance providers, we're uniquely positioned and poised for these kind of programs. We're accessible in every community. We're available 24/7, and we're an expected, respected, and welcomed source of medical assessment and care in people's homes throughout the community. This relationship that's unique in this environment that we have, it produces an unparalleled insight into those social, economical, and environmental contributing factors of health. And based upon those findings and observations, and by utilizing motivational interviewing, and we work in collaboration with the patients to develop goals and to outline steps to achieve those goals. We don't do this alone. However, it's quite a task. So as the name suggests, mobile integrated healthcare, our goal is to be a collaborative partner with the other healthcare and social entities within our community. Over the years, we have developed quite a network of community partners with whom we are collaborating with frequently to address the needs of our patients. We work with just about every hospital network in our community. We work with insurance companies, physician groups, care management organizations, home health agencies, hospice agencies, mental health agencies as well. And what we've found is that these relationships are really paramount to the success of our patients. An additional key to the successes that we appreciate is the use of motivational interviewing. But what we've found is the hardest part of this job sometimes is trying not to independently of the patient fix their problems. It can be very easy to go into someone's home and tell them, you need to do this, you need to do this, and do this. But if they're not engaged and they don't want to do it, it's not going to happen. So we do use motivational interviewing to exercise influence and to produce that motivation among that population in an effort to drive change and encourage improved health behaviors. The majority of the population that we serve has been unserved or underserved by the healthcare system, and generally speaking, they lack motivation and they're not engaged in their healthcare. So, to remedy that, each of our community health paramedics is trained on the use of motivational interviewing as a communication and interaction technique. We teach our providers to acknowledge that our patients are autonomous. They're ultimately in control of their healthcare and behaviors. It's up to the patient to become engaged. It's up to the patient to change their health behaviors, but it's up to us as providers to encourage that change and that engagement. And we do this by collaborating with the patients and with their personal, professional, and health care related goals. In my experience, when asked, patients outline goals such as time with family or experiences. I had a patient recently, her whole goal was to go to a family reunion this summer. That was her goal for the summer. And so we're able to transition that conversation into, well, what do you have to do to reach that goal? And she will tell you, I have to take my medicine, I have to go to my doctor's appointments. And so that's the degree that we use motivational interviewing. We don't tell them what they have to do, we let them define that. And generally, the plan they communicate contains beneficial consequences on their health and requires them to become more engaged in their health care. One of the more important aspects of this is we teach our providers the importance and necessity of listening. This can be very hard for paramedics since we're accustomed to being on those chaotic 911 emergency scenes where we have to be the authority figure, we have to take control and direct everyone's actions. But we teach them to do this because it is so very important. We teach them to become more passive by being an active listener. We teach them that it's important to ask open-ended questions. It's amazing how much you can learn from a person just by listening. And as needed, we'll provide some affirmation and support to promote a patient's self-efficacy. The use of reflection and summary statements, it's useful in challenging the patients and to challenge them to change their way of thinking and to promote a positive change as the patients address their ambivalence. As we incorporate these techniques into our encounters, it's important to realize that there are benefits to maintaining the bad behavior, whatever it may be. But fortunately, because we're seeing these patients twice a week in their homes, we're spending several hours with them, we build rapport and we're able to develop a therapeutic relationship. So we're able to have open conversations with them. And we ask them, what are the benefits of continuing this? And then we ask them, well, what do you think the negative consequences are of continuing X bad behavior? We let them define that. We don't preach to them and we don't lecture them. We let them verbalize and communicate that. So it causes them to really consider what they're saying, and it causes them to acknowledge it. And then that in turn leads to a discussion about the benefits of changing their behaviors. By incorporating motivational interviewing into our interactions and by developing patient-centered and shared goals, this is what we have seen. The patients become more engaged in their healthcare, their self-efficacy improves, as does their health literacy. In addition to employing motivational interviewing, we also incorporate various other interventions to promote engagement and health literacy. The vast majority of our patients have at least one chronic disease, and most have been diagnosed with a mental or behavioral health condition. So we provide them educational material that is written on a 4th grade reading level specific to their disease process. This is material that we authored in-house. It is peer-reviewed. And to couple with that, we provide verbal instruction, visual aids, to complement that educational process. Many of those community partners that we talked about earlier offer disease-specific classes, and we really encourage our patients to go to those. We'll schedule them for them, provide them with a schedule. We even provide transportation to and from, because we believe it is that important. As you can imagine, a number of our patients we see, they don't have an adequate understanding of the disease processes. They don't understand their medicines. They don't understand why they take their medicines or even how to take them sometimes. So we do provide pill minders, and sometimes we modify those pill minders, as I'll show you here in a minute. But then we talk to the patients. We listen to their concerns. We talk to them about why it's important to take your medicine, what your medicines do, and even how to take them. There's a patient I had recently. She was referred to us by our community and our county hospital. She had several admissions for behavioral health, several admissions for hyperglycemia and heart failure. She had a pretty significant past medical history, and she was on several medications. So during that first visit, when we first make contact with these patients, we do quite a bit. Of course, there's the paperwork aspect. We do a full clinical assessment, a physical exam. We'll do 12-lead EKG. We can do point-of-care testing in the home, lab testing in the home. So that all has to be done on that first visit. And in addition, we'll do a medication inventory. And so we tell the patients, gather up all of the medicines you have in the house. I have a list of what you should be on. I want you to bring me everything you have. She was a little reluctant, and she said, it's going to take me a minute. And I was like, okay, take your time. I'll be here. About 10 minutes later, she shows up with a very large box, completely full of prescription medications. There were several hundred, and they were all full. None of the medications had been taken. So, in talking to her, I was like, where did you get these medicines? And she's like, well, every time I go to the doctor or every time I go to the hospital, they give them to me. And I bring them home. I don't know how to take them, so I don't take them. So I was like, okay, well, we'll work on this. I was like, I have you a pill box. We're going to separate what you should be on from everything else, and I'm going to fill this pill box for you, and I'm going to teach you how to use it. So I thought that was going to be great. All was going to be right in the world. So that's what I did. There's one of our pill boxes there. Filled it up for her, explained to her how it worked, handed it to her. And she was less than excited, kind of had a look of puzzled on her face, a little bewildered. And so I wanted her to teach back to me how she was going to use this pill box. And she couldn't do it. And it's because she couldn't read the simple words on there. So we got creative and added some visual aids to the pill minder. I explained to her how to use it. Each vertical color is a day, and then there's morning, midday, evening, and bedtime. Now, I followed up with her a few days later, and we always check the pill minders to make sure they're taking their medicines, and she was. So at the end of the day, what does this look like from a program outcome perspective? We monitor several metrics to ensure the success of these programs. We use the Euroqual assessment questionnaire when a patient is enrolled and when they graduate. Across all categories, there is an improvement. The most impressive is the overall health status has improved by 40.1% among this population. And from a financial and cost savings standpoint, we have observed a 54.5% decrease in the number of ambulance trips to an emergency department. This represents an expenditure savings of $9.2 million, or a little over $15,000 per patient that is enrolled. Both of these outcome measures illustrate the importance of improving patient engagement, promoting health literacy, and addressing all of the needs of our patients, not just the medical needs. I want to thank you so much for this opportunity to share with you the work we do in our community. It's been an honor to be here with you today.